Okay, so we will let people trickle in through the back, but I know we have plenty of participants. So, hello, everybody. My name is Stephen Edgeluni. I'm one of the internal medicine chief residents. Welcome to Grand Rounds. Today, we are joined by a special guest, Dr. Janel Paukovits. She is the Assistant Medical Director for the Center of Emergency Medicine here at UH Cleveland Medical Center. I will begin by reading a brief bio and then we'll get started. So Dr. Paukovits is a practicing board-certified emergency medicine physician and the Assistant Medical Director at the Center for Emergency Medicine here at UH Cleveland Medical Center. Dr. Paukovits is originally from Northampton, Pennsylvania. She earned her undergraduate degree at LaSalle University in Philadelphia and attended medical school at the Lewis Katz School of Medicine at Temple University. She completed a residency in emergency medicine at University Hospitals, Cleveland Medical Center, and a fellowship in emergency medicine, clinical operations, and administration at University Hospitals, Cleveland Medical Center. Dr. Paukovitz's expertise includes operational improvement, particularly in the areas of stroke, sepsis, and chest pain. Welcome, Dr. Paukovits.
All right, we already addressed in check here that I'm a wanderer, so I'm going to try to keep this mic out as far as possible. If you can't hear me, give me a shout. Like I was introduced, I'm Dr. Paukovits, Janel Paukovits. I'm going to be talking about saving lives from sepsis, both a CMC and a UH focus. This is our yearly medicine grand rounds that we do with sepsis care. And additionally, I want to let those, especially on Zoom, know that I do have Amanda Pretsch, our sepsis coordinator, here in the room monitoring the chat for anything related to what might come up. So if there's questions in there, she'll try to direct things at me if there's themes or answer them for you on Zoom. Share my clicker, just ready to go. I have nothing to disclose, not yet at least. And my objectives for today are, one, really identify what the burden of sepsis is, both at the national level and specific to us at UH. We're going to hit some of the guidelines. We'll review some of the CMS recommendations, the Surviving Sepsis campaign guidelines, and see how those align, what's supporting those, what's refuting those, and where we sit today. And then lastly, because I know none of you are reading your emails or joining any of the Epic Roadshow things, we're going to hit some of the Epic changes that are going to be going live with sepsis care here at UH. 11 days countdown now. So it's getting close and it's definitely important. Again, why here? Why now? Those of us that are in the thick of this, every month is Sepsis Awareness Month, but particularly September is Sepsis Awareness Month. So here we are with our yearly push in sepsis education. And again, with Epic changes coming up, we want to make sure we hit that as close to go live as possible so it's fresh in your minds. The burden of sepsis is actually quite dramatic. 1.7 million adult hospitalizations annually, with 6% of those, 6% of all hospitalizations with a sepsis diagnosis. It is the most expensive condition we treat in hospitals, with 40 to 41 billion actually this last reported year in Medicare costs annually, and that continues to rise. It's considerably deadly. The mortality rate average in the US is 22%. It's the leading cause of death for hospitalized patients. You put that another way, somewhere between 30 and 50% of all in-hospital deaths carrying a diagnosis on the chart of sepsis. And as we'll see, those who end up out the doors at discharge carry considerable mortality post-discharge and true morbidity. The morbidity looks quite complex. They end up with these acquired comorbidities because sepsis doesn't discriminate. It hits, you get these patients with multi-system organ failure that they continue to carry post-discharge. They just end up bouncing back and readmitted with continued infection, other infections, or other comorbidities requiring hospitalization. And then they have considerable decreased functional capacity. Like many serious conditions, they acquire decreased functionality, decreased cognition, decreased independence, that all ends up leading to this decreased functional capacity, but particularly in sepsis. We've all seen these trajectories of chronic health and disease burden. Sepsis in general will make that long-term curve look worse with a decreased survival, but many of them have this blue line, this steep, rapid, progressive drop-off, or those relapsing. It's much more common in sepsis to have these steep trajectories downward. Now, specific to UH, we're looking about 3,500 cases annually. This has been steady for the last 3 or so years now, hasn't really budged a whole lot, but it's a decent number in the number of cases or patients that we treat as a whole. And the direct cost to UH is actually pretty impressive. So $10,000 is about where the direct cost to UH sit per episode of care for sepsis in the community sites, and $22,000 at CMC. Now, there are many factors as to why that number is so high, but a lot of it is that we have considerably sicker patients, more complex patients here at CMC. So this is not a cheap condition that we treat. You put this at 3.5 thousand patients, we're looking at $56 million cost to the system each year just from sepsis cases alone. And hammering down some of them are mortality numbers here at UH. If we look at a whole year of data, so 2022, again, right around that 3,500 mark for the system is our N. CMC was looking at 25% mortality rate. 1 out of 4 patients in 2022 that ended up chart diagnosis of sepsis died. That's a huge number. This is a very sick patient population. That's why this deserves a grand rounds. That's why this deserves all this attention. The observed over expected rate for last year for us was 0.97. Not awesome, but not over 1. So less patients died than we expected. Looking at the community population, they were sitting at 12.6% for 2022, a 0.73 observed over expected. Better, right around our target. In 2022, our goal for the system, the title of the talk is Saving Lives from Sepsis. Our goal was to save 100 lives. We met that and exceeded it. We saved 132 lives from sepsis last year alone. 132 people who were supposed to not walk out of the hospital. They were supposed to die based on, their complexity in sepsis, did not. So we saved those patients. That's awesome. Looking at year to date, 2023, CMC sitting at a 17.9% mortality rate at 0.77 observed over expected. The community sites at 8.8% mortality, 0.6 observed over expected. Don't really have to show you this, but this trend is awesome. This is the amazing result of a ton of attention, a lot of hard work, and a lot of work on your part. But there's a lot more to be done. We set our goal a little bit loftier for this year. We wanted 100 patients saved last year. We're going for 200 lives this year. Year to date, I think 146 is what we looked up this morning. So we're on target. We're on pace. That's as of probably end of June. But we want to push this number further and further. But not to be the Debbie Downer afterwards. Mortality doesn't end at discharge. Just because we save a life and it makes it to a discharge order doesn't mean that we save them from extended mortality post-discharge or morbidity. This is an analysis that saw that Medicare beneficiaries that were discharged after a sepsis diagnosis, they looked at 1 week, 6 months, 1 year, 3 years, considerable increase in mortality beyond that discharge date. For comparison, a non-sepsis hospital admission does actually carry a 40% mortality risk at the 3-year mark. The sepsis one carries an 80% mortality rate at the 3-year mark. We're doubling the risk for mortality at 3 years. 80% mortality at 3 years is a lot. So we need to not only focus on getting patients to the discharge date, but preventing mortality long-term. And we need to treat it as an emergency. You heard my other interests. There's a lot of interests in my book that are time sensitive. We talk all the time about calling BATs because time is brain. We call STEMIs because time is muscle. We treat traumas because there's a golden hour in trauma that we need to do things quickly. Sepsis is no different. It is a life-threatening emergency with a huge mortality rate that is truly time sensitive. So a lot of work to be done, finding out that it's sepsis early and then doing actions early as well. Notably, most patients nationwide, and at UH it's also true, the diagnosis of sepsis and septic shock is made in the ED. Partly how I end up standing here today as an emergency physician talking to you guys about sepsis. The problem is if that diagnosis is not made in the ED or it's not technically present on admission, we're looking at a mortality rate increase of 20% in this, particularly the shock patient group. So 30% mortality risk if I diagnose sepsis downstairs, if it makes it to you and I miss that diagnosis, or on hospital day 6, they're now in septic shock, they're carrying a huge mortality risk at 50%. So a 20% increase in mortality rate if we don't catch it sooner or if it develops later in the course. So why is sepsis so hard? Sepsis is incredibly complex. It's heterogeneous. I don't have an EKG or a CT or MRI. I don't have the mechanism directly in front of me. It's this big amorphous group of patients with different phenotypes and presentations, different sources. I don't have a single diagnostic test, despite people on the search for this elusive holy grail that may or may not exist. And the people who actually are septic, this like florid, bacteremic, Rigers, gram-negative, positive cultures, and multi-system organ failure, they're not the standard. That's not the majority of cases that we're seeing. Most patients will never even have a positive blood culture. The ones that are hardest are that, little old person that's just off. You've got to be really vigilant and it's really hard to pick up. There's so much overlap here, as you can see, with other differential diagnoses like pancreatitis and trauma. There's other things other than just bacteria causing sepsis. It can be really muddy and murky to figure out. So let's take a walk back and talk about how we figure it out and where we've come from. Now, this next few slides get like controversial and messy, and that's fine. We're going to talk about it and discover what is still true, what isn't, some of the evidence that exists and what doesn't. So going back to 1991, Sepsis 1. They came up with these definitions. Sepsis was just SIRS plus infection. Severe sepsis was that plus an organ dysfunction. And then shock, as we know it, sepsis plus refractory hypotension. 10 years later, Sepsis 2 met, really didn't change a whole lot to the framework. But then Sepsis 3 in 2016 said no to SIRS, got rid of severe sepsis as an actual category and just called sepsis itself as this life-threatening organ dysfunction that was caused by a dysregulated host response to that infection. So essentially just severe sepsis is now sepsis, and we still have shock. And they leaned on SOFA. This introduced SOFA for the first time in the framework of sepsis, that infection plus an increase in a SOFA score of 2 or more equaled sepsis. SOFA, that sequential organ failure assessment, is this predictive score that's used to risk stratified patients with organ dysfunction. But it's not exclusive to sepsis. It can be used in other critical illness. However, it's really meant for an ICU cohort of patients. There are scores that are developed at 24 hours post-admission to the ICU and then analyzed every 48 hours. It increases mortality if that score is increasing, but by the time you get to this SOFA score and this obvious demonstration of an increase, you're likely way past any ability to intervene. Where it gets particularly messy is that CMS came up with SEP1, this quality measure with a 3-hour bundle and a 6-hour bundle that would be publicly reportable and scored upon. And they snuck it in 2015, right before Sepsis 3. So you have this malalignment of definitions and quality measures that are implemented. SEP1 leans on the Sepsis 1-2 definitions. They still go with SIRS and severe sepsis and shock categories. They don't utilize SOFA. So this is where this is a little bit like butting heads between compliance with some bundle and metrics and Sepsis 3 definitions, and we get a little bit messy here. A lot of people argue that Sepsis 3 definition relying on SOFA is simply too late in the game to really respond to these early triggers and affect outcomes. Additionally, throw into the mix here, you have the Surviving Sepsis campaign. This group was formed in 2002 with an intention to get guidelines out there every 4 years. First set of guidelines out in 2004 with a goal to improve sepsis awareness and more outcome focused, improve survival through evidence-based guidelines. It's a joint initiative between the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, and provides background for really most of the sepsis management tactics worldwide. All in all, these are a lot of different bodies and recommendations out there that aren't perfectly aligned with each other. It gets messy, it gets controversial. We could spend all day picking apart the SSC guidelines, the SEP1 measure, sepsis 3 definitions, and the supporting and refuting evidence for every little data piece. We're really not going to do that because you would hate me, but we're going to look at a couple highlights of it. And this is the take-home sort of message. I want all of you to remain suspicious and keep it on your differential for sepsis if there is a possible infection, even if you don't have proof yet, and signs of organ dysfunction, even if you don't have proof yet. Additionally, if there's signs of organ dysfunction and you're seeing increasing organ dysfunction and you don't have a reason for it, to keep sepsis on your differential and keep it in the forefront of your mind, because if we get too far along the pathway without intervening is when we start to see trouble. Going to spend a couple slides just telling you what SEP1 entails, partly because you just have to know that it exists and know some of these bundle compliance measures. They go by the severe sepsis and the septic shock definitions still. Granted, sepsis 3, severe sepsis is just sepsis, but they're only going to look at those anyway that are sepsis and septic shock by sepsis 3. So what does CMS want? You need a lactate and a repeat lactate if it's greater than 2 or equal to 2. Cultures, preferably before the antibiotics. Antibiotics, all within 3 hours. If they fall into this septic shock picture, meaning their lactate comes back at greater than 4, their systolic blood pressures are less than 90, or their MAPs are less than 65, you end up in this lower portion, and they need a 30 cc per kilo fluid bolus. With the caveat that thankfully, a year and a half ago now, they allowed us to specify a different target should we not wish to give that much fluid. You just have to say so, and we'll talk about how you're going to say so later. If you're in that lower bucket, you need that repeat lactate again if it's greater than 2. You need to initiate vasopressors if they are not fluid responsive or if you're seeing fluid harm develop as you're giving that fluid bolus. And then the sticking point that we just get stuck with that is a technicality is this reperfusion examination. It needs to be stated that you're doing a reperfusion exam or a sepsis reassessment, and it needs a timestamp. So I can't guess when you re-examine them. I needed to be, I performed a sepsis reperfusion exam at 12:21 p.m. on this patient. And we'll talk about what that's going to look like in EPIC as well. Why this causes us so much headache and why this is actually really difficult, especially in a teaching hospital, but really system-wide and nationwide, is one thing, one checkbox you miss, you're done. It's an all or nothing compliance measure. So you do not get credit if any one of these things is missed. So do we care? Do the bundles work? Are they worth anyone's time and effort? This is referencing a New England Journal of Medicine article from 2017. It looks at New York State bundle monitoring because there's a really good database there. They really stringent and collect their data on sepsis bundle compliance very tightly. Looking at 2013 bundles in New York State, there was a delay in bundle completion and antibiotic completion actually increased the risk-adjusted mortality at 1.04 per hour. This is a huge N, 49,000 patients with sepsis and septic shock, and their overall mortality was at 22%. Again, referencing that average US mortality right on target with 22%. But no association between the timing of fluid completion and mortality benefit. There's a decent compliance here in the community, especially in these community sites at 82% with that 3-hour bundle, but the teaching facilities were right around 19%. So not all that dissimilar to some of the struggles that we have at a teaching facility. Further analysis of this bundle actually showed continuing drop in length of stay and mortality year after year, the longer you stayed in compliance. And a lot of this is just practice creep. So the longer you stay in compliance, the more you're good at these things, the longer it has time to take effect, and the more drops in length of stay, mortality improve. Another look at bundle and whether or not it works is this article from Chest in 2021 titled SEP1 Compliance Effects on Mortality and Medicare Sepsis. Just looking at a Medicare cohort here, 123,000 patients from 2015 to 2017. This is a propensity score matched study with a primary outcome of 30 days mortality. This is compliance with everything. You couldn't miss anything, the whole bundle. The absolute risk reduction was 5.67%, and the length of stay was shorter by 17%. So both of those things continue to demonstrate improvement here. There's a lot of studies that look at whether or not these bundles work, whether they move the needle on mortality, length of stay, cost, what have you. There probably needs to be a little bit more detailed risk adjustment looked at this to truly assess whether or not some of this is just correlation versus causation. But big picture, there's definitely some correlation that happens here. Pivoting, 2018, Surviving Sepsis came out with their next 4-year recommendation guidelines, and it was a 1-hour bundle. Because if these bundles are so helpful and we're improving things, why not get more aggressive? So this 1-hour bundle in 2018 said all of this stuff within an hour, lactate and remeasure, blood cultures before antibiotics, give the broad spectrum antibiotics. This did not hold back or give any asterisks. It was a 30 cc per kilo bolus, and then initiating vasopressors. This ruffled feathers. So not only did the SEP1 measure ruffle feathers, but also this 1-hour bundled ruffled some feathers. A lot of the emergency medicine bodies essentially said, like, we do not recommend implementing this 1-hour bundle in its present form in the US. And it got support from many other organizations as well. Annals of Emergency Medicine published that the treatment bundle, the guidelines outpaced the evidence behind it. And then the IDSA, which got support from just about every governing body, said they recommend serious revisions to the SEP1 quality measure. Again, controversy, disagreement, malalignment between many of these things. Up to 2021, our most recent Surviving Sepsis guideline. You can QR code this. I'll have the chiefs distribute this as well. But what this came down to is a series of recommendations. There are many. We're going to highlight the most important ones that are actually practice changing for you. This first one essentially says, we do not recommend QSOFA, at least over SIRS, NEWS, MEWS. So whatever screening tool works in your institution, they're not recommending just leaning on QSOFA the way that prior guidelines had. A meta-analysis in Chest actually found that SIRS outperformed QSOFA for sepsis diagnosis and mortality. So there's some evidence for many of these, but a lot of times the references or the studies show that QSOFA and SOFA are just far too late in the game. Something that we use particularly here at CMC, and you may hear of or been talked to about, is RADAR. This is a real-time assessment of data and risk. It's an early warning scale that uses mostly EMR-generated vital signs that can either pick up that early deterioration or acute changes in patient demonstration. It's calculated in the background all the time by the EMR, and there's an auto page that generates to the rapid response team if you hit 7 or higher. It's loosely based on news, but there's not a mentation piece because all scripts, and it's hard to tell the EMR exactly what a mentation change is looking like. So 7 or more is an auto page to the rapid response team and the sepsis RS team here at CMC that helps that sort of huddle and swarm mentality to start looking at patients in that early deterioration phase. Moving to the 2021 recommendation on antibiotics, this is what I want you to all take home and look at and recognize what I'm telling you to do. Antibiotics in 1 hour for patients in shock with possible sepsis. So this whole left column is the patient is in shock. Sepsis is either definite or probable. I hope I'm not having to encourage like real quick antibiotics in that group. But that's what we're looking for, 1 hour of recognition. And then if it's even possible in patients in a shock state, the evidence here says that the risk of delaying it further than an hour is not worth it. Giving antibiotics as quickly as possible in the shock state with sepsis even possible as on that differential diagnosis is important. Where there becomes a little bit more of a decision tree is when they are not in a shock state and sepsis is possible. If you're pretty sure that sepsis is definite or probable, even if they're not in shock, we're still looking about an hour. We're trying to get antibiotics in that patient in an hour, and we'll look at some evidence. But if it's possible, this is where you have a little bit of time to sit and think. So their recommendation is this rapid assessment of infective versus non-infective, looking through the differential of acute illness, finding other potential diagnoses, getting that CT to look for a source of infection, working them up a little bit more, and you have 180 minutes to do so, to get antibiotics in them, if that infection concern persists. If you've ruled it out, great. You don't have to give antibiotics. This just gives you a little bit of leeway and a little bit of time to do a little bit more thinking and work. And where's the data behind this? There's a lot of cited articles out there that, especially this Kumar paper from 2006 was like the big paper that said every hour you wait, they're going to die. There's some evidence behind that, but it's mainly in the septic shock population where this mortality benefit occurs for getting antibiotics in a patient as fast as possible, particularly that first hour. This is a breakdown of some of the subgroup analysis in this Liu paper, that septic shock patients have the most mortality benefit the faster you get those antibiotics in them. Technically, there's a statistically significant benefit to the other patient subgroups, but it's not as robust. So really the patients that need it are that septic shock group. Those are the ones that I really want you to pay attention to. If that wasn't enough controversy and a lot of money and effort spent in trials and discussion, fluids is certainly a place where there has been so much effort and so much discussion, not to come up with much of an answer, but we're going to look through it really quickly anyway. The 2021 recommendations from Surviving Sepsis changed from a strong recommendation to a weak recommendation on the 30 cc per kilo bolus question. It's still on there as a recommendation, but it's weak. The 30 cc per kilo of IV crystalloid within the first 3 hours. There's no real great prospective intervention studies that do the volume in that initial resuscitation. How did we get here to the how much fluid question? This would not be a sepsis talk, at least mentioning Manny Rivers and early goal-directed therapy from 2001. It was a huge prospective trial with many precise targets, many of which required huge volumes of fluid to hit. There was a lot of validation and challenging to that happened in the subsequent years with Process in 14, Arise in 14, and Promise in 16. But PRISM was the big meta-analysis analyzing all of these. And this aggressive fluid therapy to routine care showed no difference in all the primary outcomes. The caveat here is Surviving Sepsis came out with guidelines, evidence-based guidelines in 2004, 2008, and 2012, all these intervening years. And essentially routine care at that time was a lot of fluid. So there's a little bit of practice creep here as well that might muddy the waters. But the take-home message is there was no difference between routine care and aggressive fluid management. Classic in 2022 was this restrictive approach versus liberal, but only in the ICU and septic shock patient population, and they saw no difference as well. This also comes with the caveat that there were huge numbers of protocol violations in both arms. And before they got to the ICU and shock with randomization at that point in time, many had received an average of 3 liters prior to even getting randomized, which we know is quite a decent amount of fluid. So my take-home message here is that we still don't know. We still know if there's a difference, and there hasn't been great evidence to prove either way. We do know that too much fluid can be harmful. Not going to belabor the point. You all know this. We have multi-system issues with too much fluid, too much volume. And there's a large national database analysis referenced here that showed an increase in 2.3% mortality and $1,000 cost for every liter that was given greater than 5. So getting into those higher volumes often ends up causing more harm. What kind of fluid? Continued debate and a lot of money and time spent here as well. So SALT ED was balanced versus saline. This is the non-critically ill population. Really no difference in length of stay. The balance had a little less major kidney adverse events. SMART, same thing, critically ill population. The balance actually had less 30-day mortality and less major adverse kidney events. Then Basics came along. This was no survival difference except in the subgroup that had TBIs that showed that saline actually was a benefit. And then Plus, most recently last year, balanced versus saline, no difference. So the take-home message here is that, except in TBI patients, this may not matter as much as we think it did. May not be the hill to die on. Early vasopressors. So if fluid's so bad, let's just start pressors. Several people looked at this as well. Sensor was the early use of norepinephrine in septic shock resuscitation. It improved shock control at 6 hours. The incidence of cardiogenic pulmonary edema and new onset arrhythmias were lower, but 28-day mortality didn't change. And then Clover's most recently was actually stopped early because they found no difference in 90-day mortality and no safety concerns. So again, kind of a wash. Here's what the Surviving Sepsis Guidelines for 2021 tell us about vasopressors. Norepinephrine is first line and targeting a MAPA 65. Nothing groundbreaking here. We know this. This is based on strong quality of evidence. Consider starting peripherally. At UH, we have a policy, 8 hours on a peripheral IV is perfectly fine. Preferably AC or above with a good IV, but there's time there. You can start vasopressors early with just a peripheral. They do want you to move to vasopressors if harm's developing while you're fluid bolusing and they're not responsive. And then there's some considerations here about moving to sort of second line and third line options. What's next to come, Surviving Sepsis campaign, is we're likely to see some new guidelines in 2025, since the last ones were 2021, and it's about every 4-year cycle. One of our own, Dr. Kenneth Remy, one of our pediatric and adult critical care colleagues, was actually selected just last month to serve as an international expert for the development of both the upcoming pediatric guidelines due out next year and the adult ones to follow. So great news there. And then what else is next? There's a lot next, but big data and AI is going to play a huge part in what comes next on the sepsis care forefront. We have so much data of these patients. It may not all be that accessible in Allscripts EMR, but hopefully for more to come with Epic. But globally, there exists a ton of data for septic patients. Being such a heterogeneous condition and with all these different phenotypes, the more we can drill down on this data and use artificial intelligence to predict both early prevention and screening and how to better treat, the better off we will be with sepsis care. Again, we're all still searching for that holy grail of tests that will tell us that this is or is not sepsis. And then a big one that we can really focus on just in our day-to-day lives is preventing and managing those acquired comorbidities. Getting patients out of bed, improving their nutritional status, improving their access to different rehab and therapies, managing those comorbidities that develop when they're in these multi-system organ failures. There's a lot of work to be done on that front. And then precision treatment. We've got several people here at UH that are playing around in this space and doing a lot of fantastic research, but targeting therapies to a particular patient, a particular source, the sequencing of particular bugs that are causing their sepsis, immunotherapies, targeting direct things towards each individual patient. There's a lot of work to be done there as well. And then 3 weeks ago now, we just came out with some new CDC standards about how we combat sepsis on a hospital level. 7 core elements needed to tackle sepsis for each hospital to ensure optimal sepsis care. They acknowledge it's complex. It requires a lot of coordination across multiple levels and multiple versions of caregivers, and having different programs to both monitor, screen, educate, report, all these different areas. So more to come on this. We just sort of received this a couple weeks ago, and we're going to be developing some new things to make sure we're hitting that, the new standard. I'm going to pivot a bit and talk about UH care, UH sepsis, and how we're going to care, especially for the adult patient. We simply don't have the bandwidth at the time today to hit pediatrics, but there's a lot of additional resources I'll share with you about how to look at that. But we're going to talk about the adult septic patient at UH and the new process that we're going to be following. A lot of it's the old process with some tweaks and some Epic insertion, but this will be a high-level overview of what you'll see in the next couple of weeks. Namely, how the triggers will show up and how we're screening for sepsis. There's going to be 2 new categories. This yellow bucket, sepsis yellow, that's kind of our watchers. I'm not sure about you kind of patient. And sepsis red, that's your, I think this is sepsis. They are a sepsis alert or sepsis red. How we're going to notify. In the ED, we're going to be calling sepsis alerts. In the inpatient space, the bedside caregivers are going to be asked to call the providing team taking care of them due to their concern for sepsis or their answers to some of these screening questions. We're still working out how the rapid response and especially at CMC, the Sepsis RS team will be responding exactly based on the new EMR triggers, but there will be a particular presence of the rapid response team, or here at CMC, the Sepsis RS team. Huddling. We're going to push again for huddling because care coordination and the team-based approach really does affect care in sepsis. So is this sepsis? We need to say these things out loud and put it at the forefront of everyone's mind. We want to discuss any barriers to care, source control, IV access, antibiotics, allergies, availability of antibiotics on the floor, things like that. And we really want to make sure we're getting the orders in the computer. We're hoping that with the EMR switch, all scripts won't be cutting us off at the knee so much with getting orders in a timely manner. So using these order sets, and I'll show you what they're going to look like going forward. And then reassessment, sort of stabilization, resuscitative phase. Similar to the guidelines that we discussed, 60 minutes for that sepsis red or sepsis alert group to get both the fluids and the antibiotics in. And then don't delay antibiotics if you just can't get cultures, and continue to reassess. If we end up in this watcher bin, this yellow group, the idea is to get the antibiotics in within 180 minutes, aligned with that surviving sepsis guideline from 2021, and then reassessment. 2 hours is the expectation you would be reassessing the patient in the ED, 4 hours in the inpatient space. I'm going to show you sort of what the initial ED facing screen and trigger might look like, and then quickly move on to the inpatient group. Because in the ED space, there often is not a whole lot of data to go on. It's mostly vital signs. It is driven by SIRS to start. So these are your SIRS criteria. You know these. If we are yellow in the 2 SIRS box, we just have 2 of these things. Notably, we have excluded heart rate and respiratory rate alone. Every patient that just came through the ED that's shot is going to alarm on those, and we don't want alarm fatigue. We want to keep that specificity up, or improve that specificity and keep that sensitivity up. So we've excluded those. And then the red group can be 2 if it's febrile with leukocytosis, because importantly, that is more likely to end up in the sepsis pathway and a combo of any 3 SIRS. So that's what's going to cause the initial trigger. This is the nurse-facing trigger, or BPA. You'll hear BPA a lot in EPIC training as EPIC goes live. This is the best practice alert. And this is what they will see. The patient meets 2 or more SIRS criteria. It's a yellow. The nurse will be asked to screen for potential signs of organ dysfunction that the chart just doesn't know about yet. So that could be just simple like, yeah, they're infected. I see it. They've got invasive lines and catheters. They're on chemo, things that should be pretty forward-facing, but the EMR may not know about it yet. If they're obviously altered, and then they get them down here into reasons to exclude, okay, the active laboring patient, maybe they pause these alerts, or the trauma patient, maybe they pause these alerts. At the end all be all here is you either continue routine care, make them a sepsis watcher, or the yellow bucket, like, I just don't know yet, I'm gonna keep watching. Or you make them a sepsis alert. You say, yes, this is probably or possibly sepsis, and falling into that bucket. Quickly noting what the red one will look like. Again, this is nurse facing. Similar, but they're hitting 3 SIRS in this particular screenshot. And there's a little bit less questions here. Like they're less concerned about additional data because we're already falling into a red category. And you're giving your screen outcome right away. Sepsis watcher, sepsis red, and then automatically asking for a huddle. So prompting people to huddle sooner and more regularly. The inpatient screen will most often be when they're inputting vitals, because it'll use that plus other data that it already knows. And they'll see something like this. They meet SIRS criteria, screening required. And it too will prompt them to give a little bit more data. So same kind of questions, organ dysfunction, concerns for, chemo, active lines, drains, things like that. And then the same things, giving a screen outcome. If the nurse selects to put a patient as a sepsis watcher, a sepsis yellow, it will prompt them to order a lactate if one's not already in there recently. So just so you know, there may be lactates that are ordered based on this outcome in order to complete the sort of picture in looking for more organ dysfunction. On your end, the provider end, you may see this screen come up. Consider initiating sepsis protocol if they're meeting some SIRS criteria and if the lactate is here. Here, it is not a sign of organ dysfunction. It's less than 2. So it'll give you this sort of yellow discussion. Do you want to say, I don't suspect sepsis. Continue to watch them or call a red alert. Again, gives you reasons to suspend. Gives you a way to say that, no, this patient is comfort or palliative. We're not going to continue with alerts for this. And then it also allows you, say, your consultant that isn't providing active primary service care, to select that as well. The snoozes, the snooze options that are here, by the way, are if you select watcher, it will reprompt in 4 hours. If you select, I do not suspect sepsis, if it surges again, it will give you another alert in 24. If we end up on a red, because the lactate came back as a sign of organ dysfunction, this is at 3.5, and they've, got SIRS 2+, it'll automatically take you to this, would you like to launch the sepsis order set? And would you like to designate them as sepsis not suspected, watcher, red? Again, gives you these abilities to say comfort, palliative, or another reason. Additionally, Epic will have some logic built in that if you already have an antibiotic ordered with an indication like pneumonia and you SIRS and there's signs of organ dysfunction, it's going to say, hello, this is sepsis. It kind of tells you and guides you into that sepsis care pathway. So you may see a couple of different versions of this, all in this red heading, because these really fall into a sepsis alert category. You can get right into the order set from here, trying to put it in your face as much as possible to encourage use, or you can go hunting for it on your own. So typing in sepsis will bring up the sepsis order set. So initial management and continued. This is not a practice change. This is similar, identical to what it is currently in UH Care. So not trying to create too many new practices for you. I'm not going to go entirely through the order set, but it looks fairly similar, just in Epic form. Again, a lot of people are fussy that they can't clear some of the orders because they don't want all the stuff. There's still a clear all orders button. If you just want to go in for something particular, you can negate the rest of them. And Epic actually makes it a lot easier if you've got some duplicates to get rid of as well. Similar to current state, you will have IV fluids in here with your shock state fluids. Even if the patient's not currently in shock and you want to give fluids, I encourage you to select from this section, because in 3 hours, when they do end up in shock or someone labels them as shock differently in the note, the fact that you clicked one of these targeted boxes has verbiage in it that says, I'm targeting 1 liter due to concern for fluid overload. So it allows you that opportunity to not fall into the 30 cc per kilo bucket every time. You get to guide the care based on your best clinician judgment. And additionally, the antibiotics, again, are listed out by disease process. This has been vetted and updated by pharmacy and ID a few times over, most recently last year. This drops down to give you all the different categories, whether this is a neck fash concern, whether this is a concerns for MRSA, there's all these different sections, like meningitis breaks out into different buckets, or there's also your house wine version of the unknown origin with vancomycin already ordered for you. I encourage the use of these to start. You can get particular change doses, target therapies later on, but these groups of antibiotics have been vetted and are the doses and the pre-mixes available for the nurses to grab quickly from the Omnicells on the floors, in the ED, and the PACUs, everywhere. Quick note about, there's also going to be an ability to document about sepsis huddles. This can be from a nursing or a provider point of view, but the ability to say that we huddled, we discussed who was present and the outcome. And there's going to be a few ways in Epic to potentially create more visibility of both process and outstanding tasks for sepsis. You call someone sepsis alert, sepsis red, it's going to show up on the left side of the sidebar here. And if you actually just hover over this, it'll launch this out. It gives you this timer since you started sepsis protocol, which the ways that this timer can start are order set use, unless you go and uncheck it, or labeling them as like start sepsis protocol or sepsis red. This isn't like a chart abstraction times 0 that truly CMS is going to look at, but it gives us an idea. And then there's all these outstanding things that you can see here, and the entire navigator will also break out to show you a fluid resuscitation summary, their vital signs, the cultures that were collected, their lactate that came back. It's a one-stop shop and one-stop dashboard to show you all things sepsis-related care to look at. If it doesn't auto-launch, you can actually click on your little wrench in Epic and add it to a patient chart as well. Additionally, we've been using these like paper checklists for years that go missing or can't find. They will still exist. You will still be able to reference them as a paper, adjunct, but now the checklist will live in Epic and live on the right side. Everything will be red until you complete it, and then it turns to a lovely shade of green. So a good visual reminder of the outstanding tasks to be done. Lastly, this sort of to hit the bundle, is the reperfusion exam. It's no longer some clinical event note or some random paragraph at the bottom of your note that you have to remember to put in. There's a reperfusion exam note that you can access from either clicking on the Sepsis Navigator section or actually from the sidebar. It'll prompt you to go there as well. It is time-stamped upon opening, so we don't need to harp on like making sure you type out the time, and it'll automatically import vital signs that were most recent. You can use these pink smart lists and drop down for this reassessment, or you can delete them in free text. And there's also this opportunity here to say, I didn't give 30 Cs per kilo because, and have that rationale explained there. Epic will also give us a monitoring list. There's both watchers, so the yellow group, and the sepsis alert or red groups. This is going to be house-wide. So each individual hospital will have a sepsis monitoring list. Granted, like on an individual service, this may not be as much utility to you, but I encourage you to check it out, look at it, because it gives us a nice high-level view of the things that are outstanding. And then in the sepsis alert ones, it even has the sepsis timer on each one there, time since sepsis protocol started. Particularly, this is advantageous to us that continue to monitor sepsis on the whole hospital level, but it's a great resource, and I encourage you to check it out. The way to get to it is going to your patient lists, sepsis management, and they live in there. You can favorite them if you'd like to check them out more frequently, but that's where they live. All right, lastly, I want you to know who you have working on sepsis and championing sepsis across the system and here at CMC. This is the system sepsis HRM, the high reliability medicine group, captained by Dr. Goldstein, the CMO of Ahuja, and then Dr. Hughes. Marsha Cornell is our nursing clinical lead for the sepsis HRM. Thomas Knowles is our operational effectiveness lead. And then Mark is our Cleveland quality lead, but has a role at the system HRM level as well. And then us. So I am your ED physician lead here at CMC. Amanda Pretch is your coordinator. Again, Mark is the quality lead. And then familiar faces to most of you, we have Leila Sankari and Dr. Hajal, both pulmonary and MICU attendings here, and they are the inpatient lead and also the lead of Sepsis RS. Those of you that don't know yet, Sepsis RS includes like a MICU outreach onto the patient floors. It's the rapid response team, a MICU like designee, usually an APP, and then that primary team encouraging huddling and discussion about a septic patient. They also continue to monitor that list of patients, auditing it, and then looking at that data, how we can better improve. Across the system, we are improving and expanding our group of sepsis coordinators. We've got people at most sites now. So there's the HRM level, there's the CMC team driving, there's sepsis coordinators at all these community sites. But really the most important piece of this care is you. We can't do any of this work. We can't save more lives from sepsis. We can't drive our goal higher and higher without collaboration and work at the bedside, on the front line. So this is you guys, this is nursing, this is everybody involved in patient care to recognize patients early, keep them as healthy as possible, and then prevent a lot of these downstream effects we've discussed. So bringing it all back together, sepsis is quite deadly, very morbid. It's incredibly costly, and it's really, really, really prevalent. The regulation of the guidelines, they need some work. There's a lot of further work to be done, but we really do seek to improve the outcome. The guidelines are all driving on outcomes. And there's a lot of future advances to come. Big data, precision medicine, earlier diagnosis and screening, and then managing those comorbidities and keeping patients alive, not just to discharge. I want to bring your awareness to a Sepsis Awareness Month article that was just posted on the DWP. You can access it via this QR code and link, but it's written up by Dr. Goldstein, has links to these lectures, as well as a bunch of Epic workflows, a bunch of our data from the last couple of years is in there as well. And then again, because no one's reading their emails or doing their Epic things, this is the Epic Critical Change website, not just sepsis. This is all the big stuff. This is code management. This is restraint documentation. This is sepsis. This is a lot of really big critical changes live on this website. The sepsis one's at the bottom. You got to scroll all the way down. But this is what's listed there. There's different videos of the EMR demos. There's the summary slides. There's flyers. The PED stuff is there too. If you don't have this, you don't scan the QR code, the homepage, Epic in the top right corner, you can get right there to the Epic, to the critical change website. Right on time. Thank you all. Thanks for your attention. Thanks to those on Zoom. Any questions in the chat or live we can take, and then that's my email, how to reach me.
Thanks so much. I see Dr. Freese has a question, and a really terrific talk, and thanks to you and the team for all the hard work on this. It seems like one of the challenges we have is finding the sweet spot between the surge criteria, which was too sensitive, and the SOFA criteria, which are too late. And it seems like in the sepsis world, people are looking for that sweet spot, between too much sensitivity and too late with specificity of SOFA. Any comment on that?
Yes, there's a ton of controversy in trying to find the sweet spot. There's been some evidence about news and muse, but it's also not all that specific, and it tends to require a little bit more lift to get some of all that data. But that is where a lot news is very similar to our radar screen. I think there's still work to be done on the best screening modality, and I think it's different in different spaces. So that's why in the ED we do rely on SIRS a little bit more, because you just don't have a lot of data. And then there's a little bit more on the inpatient side pushing on news and change over time. I think SOFA and QSOFA still have a role, certainly in watching trajectory and watching deterioration over time.
Yeah, I mean, QSOFA involves change in mental status, which is late-ish, right? So anyway.
And the EMR has a very hard time figuring that out. So we rely on provider input and bedside nursing input.
Jihan put her question in the chat, and I can read it, Janelle, if you can't read it.
I can see it now. What's the positive predictive value of the EPIC sepsis alert? Concerns several years ago that's not very good at an EPIC. Okay. Yes, there's a bunch of data out there supporting EPIC sort of scoring system, but also a lot of data saying that it wasn't all that great. Partly what's going to happen is that 60 to 90 days post go live, we're actually going to look at our UH specific data and how it's performing comparatively to the EPIC scoring system, and then make some decisions from there about how to weight things and what changes we may need to make going forward. So I agree, it's a work in progress, and we have the ability to sort of massage it and make it fit for us a little bit better. So I'm hopeful, but we'll see. I don't know that I can speak as intelligently about our radar score and our performance. Dr. Hajal has done a good amount of data collection and auditing analysis of that data about its predictive value. And she's had some discussion about it. I don't know that it's perfect. And I think Allscripts has also been a little bit difficult in helping them to get as much of that data out as possible.
Yep. For those of you in Kulas, I think we peaked at 80 on the Zoom, so good attendance on the virtual. Stephen or Janelle, any questions within Kulas?
Nope, not on our end. I will hand it back to Stephen. Oh, you don't know if you need that.
Well, thank you so much. This was an excellent discussion, something that's so important for all of us in the room, all of us in Zoom, everyone in this hospital. This is something that is extremely important. So thank you so much again, and that'll conclude today's Grand Rounds.